Music season,
Yes,
no? You want to repeat it. Yeah. Actually, I'm not able to go to the. I'm not able to shrink the screen and go to the level where I want. I have to go every time to the whole thing. I'm not able to collapse this full screen. Why is that? Try stopping and then try. Is it visible now?
no, sir.
No. Happened? I missed the screen itself. Is it visible now?
Yes, sir.
So, what is transcutaneous blood gas monitoring? And what is the principle behind this? Have you ever heard of this particular equipment?
Yes, sir.
What is that? Transcutaneous blood gas monitor.
So,
When you say transcutaneous, is it invasive or non-invasive?
non-invasive techniques, sir.
Non-invasive. So it is a non-invasive method used for rapid measurement of gases, especially in infants. Okay. Works
Based
on the
on
principle that capillary PO2 will approximate to arterial PO2 when skin is warmed because of the increase in blood flow, which is more than what is required by the tissues. So you will be able to get the capillary blood oxygen content will be almost equal to the arterial oxygen content. So when the just of warming the skin produces this. So that is the concept or basis on the for measuring the blood gas through the skin. So this is the equipment. You can see this is the warmer which is there to locally increase the temperature of the skin without causing any burns. And this is the sensor, and it has measured even the CO2 level. With 33.9 is the CO2 level, which is measured by the simple sensor here. And what is inline gas monitoring? What are the advantages of that? Just like your transcutaneous, there is another method of blood gas monitoring called inline gas monitoring. Heard of that? No.
No,
The
sir.
continuous inline monitoring refers to the technology that allows for the continuous measurement of blood gases like oxygen, carbon dioxide level within the patient's bloodstream, achieved by inserting a small sensor directly into the artery, providing real-time data on vital gas level without the need for repeated blood samples being aspirated and sent to the lab or introduced into the blood gas machine. So this is how the whole thing looks like. This is the artery. This is the temperature sensor. This is the fiber optic cable. So along with your intra-arterial monitoring, you can use this also. It's probe into the artery, and that will give the reading. So this is the setup. This is the arterial line that has been inserted. And you have a sensor here which is attached. Then the whole other communication like stop bag, the pressure bag, all these connections are there. Advantages of this, it gives a continuous data. It can detect the LTD events early. There is no loss of blood because it is inside the vascular vessel. No need to draw blood and send every time. So there is no loss of blood, less time needed because it's a continuous display. The less risk of transmission of infection and trend analysis is also possible. Okay. What are the artifacts which will affect the values of a ABG sample? When you take a arterial sample and send it for analysis, what are the artifacts which will affect the value? This is an easy
Presence
question.
of air bubble.
Air bubble, very good. Okay, then how should it be stored and transported?
Heparinized, sir.
Wherein, temperature of transportation. How soon after taking the sample you should analyze it if you are drawing the blood sample? What is the time limit before which you should analyze it by feeding it into the blood gas system?
No
Can you do it
idea.
after 1 hour or 2 hours? 20 minutes. Okay, delay in analyzing the sample can affect the pH and gas values. So maximum time is 20 minutes within the filter, and it should be transported at a temperature
Ice.
of 4 degrees centigrade, and air bubble should be avoided. Did I show this slide in the last class?
No, sir.
No, sir.
Okay. What is shown here?
Burns.
Thermal bands.
Burn. What type of burn? Minor, major?
This is major burns. It
Major
includes the
burn. Why
face
you say
also.
it's a major burn?
It's involved in
Face
face,
is
sir.
also
Ah,
included.
patient who has sustained deep burns to upper limb, face, and head. So, what are the challenges in providing anesthesia for hysterectomy in this patient?
Difficult
Difficult
airway
airway.
and head.
Difficult airway, difficult IV access, major
Difficulty in
burn.
monitoring
Ah,
and major blood loss.
so, investigation results are CBC, all these things should be done, and clinical parameters, check for consciousness, heart rate, BP, respiratory, clearing output, and temperature. Optimize the patient based on the investigations, and monitor the renal function and maintain normal temperature. Free of NPO, acid aspiration prophylaxis, antibiotics. Blood reservation is very, very important because this hysterectomy procedure will cause huge blood loss. And airway management should be well planned, how you are going to manage airway. And intraoperative difficulties may be because of positioning, mask ventilation, plus achieving control over airway, placement of monitor, IV access, increased need for drugs. Just remember to avoid succinylcholine because of the fear of hyperkalemia and arrhythmia. Blood loss, patient is likely to go in for hypothermia. They can contract infection and sepsis very easily. Post-op, they may require adequate analgesia, circulatory stability. They must have a normal renal function, temperature maintenance, prevent infection, early enteral infection, and maintenance of electrolyte status. It's almost like a mini theory question paper or a practical exam question, which you have to remember. What are the challenges in providing anesthesia? The post-op ABG of this patient is this pH is 7.21, PCO2 45, CO2 120, BICARB 15, base excess 29. What should be done? First, interpret the ABG and tell what should be done for this patient.
Metabolic acidosis.
Metabolic acidosis is there. Respiratory oxygenation, is it normal?
It's high. Yeah.
So what information is missing in this? Whenever any ABG is given,
If
what
the patient
additional
is on
information you should know?
the patient is on oxygen supplementation.
What is the
Room air.
FiO2? That is
Yes.
very, very important. Okay, that is one word answer. FiO2 is always important to assess whether PO2 is of normal value or not. Because in room air, can you get 120 PO2?
No, sir.
No, sir.
Not possible. Maximum is only 100 because 5 times of FiO2, 21% air oxygen can get only maximum 100 millimeters. So interpretation ABG pH is acidic, PCO2 within maximum normal range 35 to 45,
40.
high carb 15, which is acidosis, base excess state is also acidosis. So as per this condition, it is an uncompensated metabolic acidosis, but PCO2 cannot be normal in this condition. Okay, if it is a pure compensated, PCO2 cannot be normal. So how will you identify whether the patient is, what should be the value for, if it is a compensating by hyperventilation, what should be the value of PCO2? How do you find it out?
Winter's formula, sir.
Winter's formula, yes. So expected PCO2 is bicarbonate 1.5 times plus 8. So 15 multiplied by 1.5, 22.5. So 8, 30.5. But the measured value is 45. So this is not normal for this patient. So there is a respiratory acidosis also is there. Even though 45 appears to be a normal value, you must always see whether it is compensated or uncompensated. So patient is having a uncompensated metabolic acidosis with respiratory acidosis also. Okay. And since the FiO2 is not given and PO2 is 120, we have to presume that she should be on supplemental oxygen, and 120 is not possible with room air. So if you assume that the FiO2 is 40, what should be the PO2?
Into
5 times.
5 times
So
200.
200, at least 160, 180 should be the value. So for that, it is only 120. So patient is also having a low PO. So it's a multiple disorder. Metabolic acidosis, which is not compensated. There is a respiratory acidosis. If there has been a compensation, it would have been only 30.5, but here it is 45. And patient is also having a low PO2, presuming that she is receiving some oxygen supplementation. Okay. What is evidence-based medicine? EBM. Nowadays we talk only about this. So, EBM is a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Okay, so that is the definition of it is a conscientious, explicit, judicious use of current best evidence. Because the word itself saying evidence-based medicine, making decisions about the care of individual patients. What are the components of evidence-based medicine?
Patient's knowledge,
Hmm.
literature evidence,
Yeah.
data.
The three things are there: best evidence available, practitioners' clinical expertise, and patients' values and preferences. So that is seen in this Venn diagram: clinical expertise, patient values, and the best evidence that you have. What is evidence-based pyramid? You don't have any idea? We'll go ahead with that. So it is starting from what is the basis, ideas and opinions. Earlier days, people used to say, in my experience, I have never come across this complication of doing 500 surgeries, 1000 surgeries, or in my experience, I have not come across. This sort of things will be there. That is called ideas and opinion. Then there were case reports, case series, then cohort studies. Then we go to RCTs, randomized controlled studies, and then comparison of double blind with randomized and other placebos. Okay, that is how slowly it grew up. This is called the it is a stepwise approach, starting with ideas and opinions at the base and going through case report, series, control studies to randomized control trials. So nowadays, the ultimate thing accepted as the best evidence is the RCTs. So level 1 evidence, if you say it is the, at least there is one randomized control trial, then only it can be called as level 1 evidence. And level 2 can be subdivided into 1, 2, 3. Evidence from well-designed controlled trials but no randomization. Evidence from cohort studies. Evidence from multiple time series designs. Level 3 opinion of respected authorities based on clinical experience. And so there are 3 levels of evidence. Level 1, level 2 subdivided into 3 and level 3. Of course, you can forget all this, but level 2 is less confirmatory evidence. Level 3 is an individual opinion. So this is not, nowadays not at all accepted. So we have level 1 evidence that is considered as the best evidence for practicing evidence-based medicine. Based on the level, you have some recommendations. So the recommendations also have been graded. If you say that is given in alphabets A, B, C, D, E. A means it is strongly recommended because of strong level 1 evidence. Level B recommendation means it is strong, moderate efficiency, limited clinical benefit, generally recommended. And grade C recommendation, insufficient evidence, weigh the risk and benefit, optional. You can follow or you need not follow. And grade E is the never recommended. Do not follow at all. So if any recommendation instead E, never to follow. There is a strong evidence against that particular procedure. Okay? So this is one question which can be commonly asked, and this is one of the mockup questions which we have to remember in mind. What is shown here? Describe its working principle, advantage and disadvantage.
Nasal prawns.
Nasal prawns.
Nasal cannulas.
Nasal prong cannula. Okay. It is a bi-prong nasal cannula used for oxygen therapy. That is a complete answer. Okay. When oxygen is delivered through this, what is the principle? Working principle?
Okay.
How does it help to oxygenate the patient? What happens to the dead space air? So when oxygen is
Dead space air
delivered through this, the
decreases.
upper airway dead space becomes a reservoir. Once the air there it gets replaced with the oxygen. Okay, so that becomes the storage, and it is of lightweight, easy to use, disposable, permits patient to eat and drink and talk. These are all the advantages. But disadvantages requires high flow, which may cause irritation, requires different flow rates to alter the FiO2. Every 1 liter will raise the FiO2 by 4%. So starting with 1 liter, you will get 24%, 2, 28%, 3, 32%, like that. For every 1 liter increase, you will get an increase in FiO2 percentage of 4%. Okay? And maximum you can give is 44 because beyond that, patient cannot tolerate that high flow, it will irritate the patient. And there is no humidification through that. It depends on our own natural humidifier capacity of the upper airway. There are 2 different masks shown here.
Non-rebreathing
Non-rebreathing
mask
mask.
with
Ah.
the valves and without
Left
valves.
is partial rebreather with a maximum flow rate of 6 liters, the maximum FiO2 to 80%. Right is a non-rebreathing mask with a flow rate of 60 to 15 liters, 6 to 15 liters with FiO2 possibly of 95 to 100%. Okay.
Color-coded Venturi masks.
Venturi mask.
Venturi. So adapters. Venturi mask is shown the high flow oxygen delivery system, 24 to 60% FiO2, and 2 to 15 liters per minute. It is this and when it is used and merits and demerits.
Oh, it is.
You clearly see or not? It's so difficult to find the what is this? Does it look like an alphabet here?
TP, sir.
Ah,
Oh, deep.
it's the highest TP is used mainly for weaning from mechanical ventilation. So this is the TPs. This is the expiratory limb. This is the inspiratory limb. Okay. So this is goes to the patient endotracheal tube. This is oxygen delivery supplement. So instead of the breath gas flow coming through this, it is coming through this. Okay. So it is a lightweight, portable, easy to use delivery of 40% and used for weaning. What are the features of oxygen toxicity? What is the safe FiO2?
Free radicals get released with oxygen toxicity, sir.
Oxygen toxicity, you must say which systems are affected by oxygen toxicity.
Pulmonary,
Pulmonary and central nervous system. Okay.
central nervous system.
Two people have described that. Dry cough, substernal pain, fatigue, nausea, vomiting, sore throat, dyspnea, all these things. Hypoventilation can happen. And this is described in terms of pulmonary complications and central nervous system complications, named after two people.
Lawrence Smith and Paul Burt.
Paul. And this is the safe FiO2. You can give for 12 hours 100%, 80% 24 hours, 60% 36 hours, and 50% can be given indefinitely without any oxygen toxicity. What is the preferred route of nutrition? Why? How is it administered?
Enteral route is the preferred route.
Enteral route is preferred. Very good. Why it is given? Why it is preferred?
Sir, it promotes the healthy gut bacteria, sir. So we can prevent
What is the
septicemia.
Maximum absorption.
What is the exact terminology we should use for describing that? Why it is preferred? Maintains the gut integrity. Enteral nutrition is supposed to be preferred because it maintains the gut integrity and prevents bacterial translocation from the gut into the bloodstream across the gut wall. Okay? And it is administered via nasogastric, nasojejunal, or peg tubes. So this is how the peg is being fed and the patient is taking the feed. What are the complications of enteral feed? The part of ICU question.
Sir,
Like it can be
malposition.
mechanical, metabolic, or GIT problems. Mechanical blockage of lumen or displacement of the feeding tube, discomfort, ulceration. Metabolic dehydration, overhydration, hyperglycemia, hypercapnia, electrolyte imbalance. That problem is gastric retention, nausea, vomiting, diarrhea, bloating, reflux leading to aspiration and pneumonia. Okay. What are the indications for TPN, total parenteral nutrition, and how is it administered?
Bowel obstruction.
Major abdominal surgery.
Whenever a patient cannot take by enteral route, oral route, then you have to go for total parenteral nutrition. So any condition which prevents over enteral nutrition is indicated. So whom enteral feeding cannot be started for more than 7 days, or those who are intolerant to enteral feeding. You need not go to say the individual conditions. The general principle is more than enough. And usually administered via a central vein as the formulations are hyperosmolar. But certain formulations now are available which can be delivered through peripheral veins also. What precautions are needed when giving TPN?
Good IV, in venous access, sir.
Because you are giving through central line, what is the important thing we just discussed with regard to the bundles?
Infection
Asepsis. Meticulous asepsis is very important. First and foremost, dedicated vascular access. You should not use that vascular access for other drug infusion or fluid replacement. And central vein with minimal handling. So you can use 24 hours change of infusion bag, daily measurement of electrolytes and trace elements is very important. What is refeeding syndrome? Have you heard of the terminology?
Yes,
Sir,
the
electrolyte imbalances will occur in refeeding syndrome, sir.
Sir, on feeding after a period of starvation, the nutrients will get used up very fast. Hunger.
It is the occurrence of number of metabolic disturbances when enteral nutrition is reused after prolonged fasting or PTN. Happens within 4 days of enteral nutrition. It will result in hyperphosphatemia, serious RS failure, coma, seizures, rhabdomyolysis. All can happen because of shift from earlier when the patient is starving, fat is utilized. And once you start feeding that patient, it shifts from fat to carbohydrate metabolism. And the main culprit is hyperphosphatemia. Okay, so that is what you have to take care of to treat this condition.
Hypoplastic.
Congenital diaphragmatic
Congenital
hypertension.
diaphragmatic. Yes, you can see there is a hole, so all the bowel content is in the chest. So this is a congenital diaphragmatic hernia and a newborn. What are the types of congenital diaphragmatic hernia?
Posterolateral and anterior.
So it is maybe right or left-sided or bilateral. How are the defects classified based on the location in the diaphragm?
Bogdalak and Morgagni.
Bogdalak and Morgagni. Very good. What is eventration of diaphragm?
So,
The diaphragm is weak but remains intact. It's called eventration. Okay? There's no hole or anything. The diaphragm is not strong enough to do its normal function. What is the pathophysiology in congenital diaphragmatic hernia?
there is a defect in the parieto-pleural membrane,
Folds, pleuroperitoneal membranes.
Pleuroperitoneal membrane.
which leads to herniation of
Intestine
abdominal
to the
contents into the
thoracic cavity.
thorax.
But what changes happen in the thoracic cavity? In the
So there will
bowel,
be hypoplasia
leading
of
to
lungs.
pulmonary hypoplasia,
pulmonary hypoplasia,
hypertension.
vascular remodeling, and pulmonary hypertension. Sometimes there may be left ventricular hypoplasia also. Okay, these are the three important changes that will happen because of the occupation of the bowel into the thorax, preventing proper development. Earlier the hernia occurring in fetal life, more will be the effect on the development of the pulmonary system. What is the immediate management of a baby born with CDA? Supposing by ultrasound it has been diagnosed, baby is born at 34 weeks. What is the immediate requirement or treatment that should be done?
We have
Bowel
to secure the
decompression.
airway and
There are immediate intubation, monitoring pre and post ductal saturation, aiming for post ductal saturation of 80 to 95%, nasogastric insertion with frequent and continuous suction, IV access, you can even use the umbilical vein, transfer to ICU, invasive blood pressure monitoring, and plan for early surgery. Okay, these are the things that have to be done. What is being done here?
Ultrasound guided ankle block.
posterior.
Ankle block, which nerve they are blocking?
Tibial nerve.
tibial.
This is guided ankle block of posterior tibial nerve. What nerves to be blocked in ankle block and their area of supply?
So sural nerve, saphenous nerve, superficial peroneal nerve, deep peroneal nerve, posterior tibial nerve.
Okay, so 5 nerves you have to remember. Targets 5 nerves that provide sensory information to the foot. The posterior tibial nerve, which supplies the sole of the foot. Okay, this nerve which they are blocking, almost the entire sole is supplied by that. Deep peroneal nerve between the big toe and second toe, small area. Superficial peroneal nerve, top of the foot, and sural nerve, posterolateral aspect of the foot, this lateral area, and saphenous nerve, medial aspect of the foot. So this top surface is by saphenous nerve. So now they are planning to block this deep peroneal nerve. This is the landmark that I have given. What is this 1, 2, 3, 4 structures shown here?
Alice
One
is long.
Sensor hallucis
is
is
longest.
longest.
2
3
tendons.
and 4 are medial and lateral malleolus.
Malleolus. Very good. Extensor hallucis longer, extensor digitorum longer, medial malleolus, lateral malleolus. What is Mayo block and its indication? Any idea?
No, sir.
No, sir.
Combination of nerve block and a field block that involves infiltration of local anesthesia. That is, after you give the ankle block, there is also a block that is the infiltration through tissue proximal to surgical site in a ring shape around the first metatarsal and or lesser metatarsal base. Okay, so that is
யார் கால் பண்றா
commonly used in post-podiatric office surgery to anesthetize the area before performing Bunyan or hallux surgery. This is what is being done. Can you perform ankle block in this case?
No, sir.
Why?
Diabetic,
The local
ulcer
anesthetic
won't work.
won't
Why?
take. Due to acid,
Acidic,
Contraindication.
acidic medium.
Medium. So why in acidic medium it is not active?
So it becomes ionized.
If it becomes ionized, what will happen?
It won't
will
be
neutralize
soluble to
the-
the. It is not. It does not become soluble. So it does not penetrate the.
It cannot enter the neuronal cytoplasm. Okay, with unionized form only will be able to penetrate and go into the neuronal cytoplasm. And after going into the cytoplasm, it has to get ionized to block the sodium channels from the inside, cytosolic side, not from the outside. Okay, so that is the correct answer and full explanation. In acidic medium, the pKa will be not near the pKa, I mean the pH of the area will not be near the pKa to get the maximum disposition of unionized particles. So the local anesthetic cannot enter the neurons to block the sodium channel from inside. That is the answer. So no block will not be done in this case as wound looks infected. Okay, this may be the last waveform seen in shock and leaking alveoli. Sorry. These are some of the PTCO2 tracings. First, I have given the answer. PTCO2 waveform seen in shock and leaking alveoli. What is this? Very commonly seen.
bronchospasm, sharp.
Bronchospasm,
Sharp in appearance. Waveform seen in bronchospasm.
Curare.
What is it?
Expiratory valve malfunction. Sir.
The peak it is speaking again is seen in poor compliance lung in obesity and pregnancy. Okay?
A return of
Spontaneous circulation, sir.
Turn off. Okay, very
Thank
good.
you.
Capnography in 4 situations. 4A, B, C, D. After advanced airway placement and intubation. So what is 4A? What is 4B? 2B.
B cardiac
D is
oscillation.
correct placement, sir.
Hmm.
B is endobronchial intubation. D is esophageal intubation.
You are almost right. A is apnea followed by normal waveform. Then B is airway secured but not properly. C is normal pattern. 4D is discontinuation or arrest. Here the difference between this first and second, 6A and 6B.
6B is malignant.
Hypothermia.
Rising level of free CO2. Okay, gradually the waveform is going up. So CO2 level is rising. Here it is uniform. Okay? So hypo, it is going down rather, smaller. Hypo and hyperventilation. So this hypoventilation where CO2 is building up. 6B, this is hyperventilation, it is gradually reducing the level. Okay. So for all the things. So we'll stop here.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.